Welcome to PGOG, postgraduate class in obstetrics and gynecology for postgraduates as well as for consultants. Today's topic is management of unruptured tubal ectopic pregnancy. Management options are medical management, which is preferred one, surgical management, and expectant management. Medical management, mainly we use Methotrexate. It is the main drug which is used for medical management of ectopic pregnancy. Mechanism of action is anti-metabolite and folic acid antagonist. So how it acts is, this dihydrofolate needs dihydrofolate reductase for its conversion to tetrahydrofolate. Tetrahydrofolate is the active ingredient. This tetrahydrofolate leads to the formation of purines and pyrimidines, which further lead to the formation of RNA, DNA, and proteins, leading to cell proliferation. What methotrexate does as an anti-metabolite and folic acid antagonist is, it binds tightly with this dihydrofolate reductase, because of which this dihydrofolate reductase is not available for conversion of dihydrofolate to tetrahydrofolate, and that is how it leads to the reduction in the cell proliferation, or it inhibits the cell proliferation. Methotrexate is used many times with folinic acid. Other name for folinic acid is leucovoron. So what is happening here is, as we have already seen, methotrexate is tightly binding with dihydrofolate reductase, leading to the inhibition of proliferation of rapidly proliferating cells such as trophoblast, bone marrow, GIT, respiratory system. So there will be reduction in the cell proliferation with the action of methotrexate. But this leucovoron or folinic acid does not require dihydrofolate reductase, and it directly gets converted to tetrahydrofolate, and that is how it blunts the action of methotrexate, or it reduces the side effects without reducing the or compromising the efficacy of methotrexate. So in ectopic pregnancy, how methotrexate is acting is, here is the rapidly proliferating trophoblastic cells, and methotrexate acts on these. It stops the proliferation, which leads to the resorption of the ectopic pregnancy. There are certain contraindications for the use of medical management, or for the contraindications for use of methotrexate. First is ruptured tubal ectopic pregnancy, which is suggested by patient is hemodynamically not stable, hemodynamic instability, acute abdominal pain, or clinical or ultrasonography suspicion of tubal rupture, such as presence of free fluid, significant amount of free fluid in pouch of Douglas. Other contraindications for the use of methotrexate are presence of anemia, leukopenia, thrombocytopenia, because methotrexate will further lead to the bone marrow suppression and worsening of all this. Liver dysfunction, because methotrexate itself has got a adverse action on liver, leading to hepatotoxicity, and in presence of liver dysfunction we cannot use methotrexate. Renal dysfunction, because with the elevated serum creatinine, there will be less excretion of the methotrexate and increased risk of methotrexate toxicity will be there. Sensitivity to methotrexate is another contraindication. Anytime intrauterine pregnancy is suspected or it is diagnosed, it is absolutely contraindicated, as methotrexate is a teratogen, leading to craniofacial or skeletal abnormalities or intrauterine growth, uterine growth restriction. In a breastfeeding woman, it is contraindicated because it gets secreted through milk, breast milk, and it adversely affects the neonatal growth. In acute pulmonary disease, it is contraindicated as it is affecting the proliferation of pulmonary epithelium. Peptic ulcer disease is a contraindication as there is a risk of increasing inflammation at the site of ulcer and even risk of rupture. There are certain prerequisites for medical management, such as patients should have access to easy access to or early access to emergency care, as when your patient is on medical treatment, there is always a small risk that the ectopic, which is unruptured, can suddenly go for a ruptured variety where patient will need emergency care. Patient should be willing. There should be a willingness. Long follow-up might be needed with repeated lab investigations, mainly beta HCG has to be repeated many a times whenever we are giving medical management. Patient should be asymptomatic, should be motivated and compliant. There are certain bad prognostic factors for the success of this medical management, such as beta HCG level greater than 5000 milli-international units per ml, size of gestational sac greater than 3.5 to 4 centimeters, and presence of fetal heart activity in the ectopic gestational sac. But remember that all these are not absolute contraindications, but these are the relative contraindications for medical management. Whenever we are giving methotrexate, we have to explain to the patient that there are certain restrictions which are to be followed as per ACOG 2019 whenever we are providing methotrexate therapy. First is not to take medications containing folic acid, not to take NSAIDs as they reduce renal blood flow and reduce the excretion of methotrexate, increasing the risk of methotrexate toxicity. No alcohol as it can add to liver dysfunction. Avoid sunlight to prevent methotrexate-induced dermatitis and abstinence to prevent rupture of the ectopic. There are various regimens for administration of methotrexate in unruptured tubal ectopic pregnancy. First is single dose therapy, where only methotrexate is given and dose is 50 milligram per square meter body surface area. So body surface area in square meters is calculated, and there are so many formulae which are available on internet. One example is 1/6 by WH multiplied by 0.5, where W is weight in kg, H is height in meter. So we have to just insert the values and calculator in on our mobile phone also can provide us with the body surface area of the patient. Accordingly, we have to give 50 milligram per square meter body surface area. Beta HCG is to be done on day 1 when we give methotrexate. Before that, we have to do beta HCG, and it is to be repeated on day 4 and day 7. This same dose needs to be repeated if from day 4 to 7 fall in the beta HCG is less than 15%. If or whenever even if there is a fall which is greater than or equal to 15%, and when we are keeping the patient on weekly follow-up, and weekly follow-up also shows that there is a fall which is less than 15%, we need to repeat the same dose. Once the fall is less than 15%, then weekly beta HCG is to be testing needs to be done till it comes to 0. Whenever fall is greater than or equal to 15%, I am sorry. When fall is greater than or equal to 15%, then we shift to weekly beta HCG testing till it is undetectable. On day 1, as HCG is given, methotrexate is given, 4 and 7 beta HCG testing, serum beta HCG testing is done. Fall less than 15%, repeat CBC, KFT, LFT, and repeat the dose. Consider this as day 1 and restart. That is important. Fall greater than or equal to 15%, then weekly beta HCG. Weekly less than 15%, we have to repeat the dose again after repeating CBC, KFT, LFT. mandatory CBC, KFT, LFT before repeating the dose of methotrexate is we have to remember to avoid the serious drug-induced complications. Now in multi-dose regime, beta-HCG testing is done on day 1357. Now whenever I am here I am mentioning it as beta-HCG, remember it is serum beta-HCG level. Beta-HCG to be done on day 1357. Methotrexate 1 mg per kg is given on day 1357 as per beta-HCG report. Leucovorin or folinic acid is given with a dose of 0 gram per kg on day 2468 if provided we have given methotrexate on 1357 respectively. And maximum 4 doses can be given in this multi-dose regime. So here what we are doing is again to simplify this regimen is day 1 beta-HCG and methotrexate, day 2 folinic acid, day 3 we repeat beta-HCG. If fall is greater than or equal to 15%, we don't give methotrexate or folinic acid on day 3 or 4. If fall is less than 15%, repeat CBC, KFT, LFT and then give methotrexate if all the values are normal on day 3 and folinic acid day 4. Day 5 again repeat beta-HCG and same as day 3 depending on the fall. Fall anytime it is greater than or equal to 15%, no need to repeat the dose. But less than 15%, repeat the dose of methotrexate as well as folinic acid. Same procedure is repeated on day 7. Maximum 4 doses are given in this multi-dose regimen. Fall greater than or equal to 15% once it is achieved, then weekly beta-HCG is done and it is repeated till it becomes undetectable. So this is diagrammatically again here for day 1 we are doing beta-HCG and methotrexate single dose. Day 4 only beta-HCG testing. Day 7 beta-HCG testing. Compare the values of day 4 and day 7 with each other. Fall is less than 15%, we need to repeat the methotrexate. Consider that this is day 1 and restart the whole regimen. Whereas fall is greater than or equal to 15%, then we shift to weekly testing. In weekly testing, again, anytime less than 15%, again we restart the single dose regimen. In multi-dose, day 1 we have given methotrexate, day 2 we have given leucovorin, and we have done beta-HCG testing on day 1. We repeat testing on day 3 and see how much is the fall. Less than 15% fall, we repeat on day 3 methotrexate, day 4 leucovorin. Greater than or equal to 15%, we don't repeat, we directly repeat the testing on day 5. I hope it becomes clear that it is not that we give in multi-dose methotrexate in 1, 3, 5, 7. No, it depends on how much is the fall. Fall is satisfactory. Fall is greater than or equal to 15%. There is no need to repeat methotrexate. Then once we don't give methotrexate, we don't follow it on next day by folinic acid also. Once the fall we have achieved of greater than or equal to 15%, then patient is shifting to weekly testing as in single dose. Now there is a new regimen which has been which is given in some of the textbooks, and that goes by the name of 2-dose regimen. So what is this 2 doses? It is exactly midway between the single dose regimen and multi-dose regimen, where methotrexate is given on day 1 and 4. Beta-HCG is repeated on day 4 and 7, and as per the trend of the fall. Satisfactory fall, no need to repeat methotrexate. If unsatisfactory, that is if it is less than 15%, then only another 2 doses of methotrexate are to be given intramuscularly with the same dose as 50 mg per square meter. I want to repeat it once again here, that in all these methotrexate regimens, whatever we have seen, single dose, multi-dose, 2-dose, everywhere it is administered parenterally, intramuscularly. In this two-dose regimen, dose is same as single dose as 50 milligram per square meter, and there is no addition of folinic acid. Follow-up is necessary, weekly follow-up till beta HCG becomes undetectable. So how much is the duration for the beta HCG to become undetectable is average is 1 month, but for maximum, few patients might need it to be repeated for 3 to 3.5 months for beta HCG to become undetectable. Now the single dose therapy pros and cons are it is simple, less expensive as compared to multi-dose, less follow-up is required, but some studies show that there are more failure rates with single dose as compared to multi-dose. Overall, if we see all the multi-dose, single dose regime or two-dose regime, there is a 90% success rate with all these regimens. Important point again, I want to repeat mandatory testing before we start methotrexate or we repeat methotrexate again. Every time we need to do AFT, NFT, and CBC. It needs to be repeated before each next dose. That is important. And we need to do blood group and RH typing also. What are the side effects of methotrexate? Liver dysfunction is seen in 12% of the women. Angular stomatitis, gastroenteritis, pain in abdomen is seen, and this pain in abdomen is seen sometimes after several days after the administration of methotrexate, but it usually responds to analgesics, and this pain is thought to be because of the separation of the products of conception from the wall of the fallopian tube when the ectopic is resolving because of methotrexate. Are there any long-term complications of this therapy? Fortunately, there is no effect on ovarian reserve. But what care needs to be taken is next pregnancy needs to be delayed by 3 to 6 months to avoid the risk of pregnancy because of the methotrexate. Now we start with the surgical management of unruptured tubal ectopic pregnancy, and the first technique which we will be discussing is salpingostomy. Now this salpingostomy is the procedure where tubal conservation is done, whereas the other technique is called as salpingectomy, where relatively it is a radical technique where we do the removal of fallopian tube. Salpingostomy is designed for future pregnancy. There is a small unruptured ectopic, and what is most important is contralateral tube is normal looking. So it is most important how the contralateral tube is. What is done in this procedure is a 1 to 1.5 centimeter incision is given over the fallopian tube at anti-mesenteric border. After removal of the products of conception, this incision is not sutured. Persistent trophoblastic activity is seen with this procedure in 5 to 15% of the patient women. For this reason, it needs weekly beta HCG follow-up till beta HCG becomes undetectable. If there is a persistent trophoblast which is detected when the beta HCG fails to drop, there is a plateau or there is a rise, then patient needs additional medical treatment in the form of single methotrexate therapy or surgical treatment in the form of salpingectomy. We have already seen that whenever there is a contralateral damaged tube, then we need to proceed with salpingostomy because we want to conserve the present tube, though there is an ectopic pregnancy in the index fallopian tube. Along with that, whenever there is a risk factor which has a possibility of having contralateral tube normal, then also we have to proceed with salpingostomy, such as if there is a previous history of ectopic pregnancy, history of abdominal surgery, history of pelvic inflammatory disease in the past. In these situations also, salpingostomy is preferred over salpingectomy. This is the technique of salpingostomy. What is done is with a blunt forceps, this femoral end is grasped, fallopian tube is lifted up away from the ovary so that there is a stretch over the meso salpinx. And some surgeons they instill vasopressin, dilute vasopressin, which is 5 units diluted in 20 ml, and around 5 to 10 ml is infiltrated in the mesosalpinx by taking care not to directly inject it in a vessel. So what will be seen, it is injected at proximal and distal end of this distended part of the fallopian tube, so that after instilling vasopressin, there will be a blanching which will be seen, and that will reduce the need for these bleeding points to be cauterized at the end. So more the cauterization, more there is a risk of damage to the fallopian tube, and that is why this vasopressin might help. Then a small incision is given around 10 to 15 millimeters, and the products of conception or trophoblastic tissue is removed with the forceps, or it is irrigated with normal saline. If there is a possibility of spillage of the tissue in the abdominal cavity irrigation, thorough irrigation is also done. Suturing of this incision is not done, and it is left for healing by secondary intention. Now, the second technique in unruptured tubal ectopic pregnancy is salpingectomy, where the fallopian tube is completely removed. It is for those who are not desirous for future pregnancy, and it is the technique of surgical technique which can be used whenever there is a ruptured ectopic pregnancy. It can also be used for unruptured ectopic when the normal looking contralateral tube is present. Then salpingectomy is preferred over salpingostomy in those desirous of future pregnancy also. The reason is risk of persistent trophoblast is not there with salpingectomy, and future intrauterine pregnancy rate is same with salpingectomy as well as salpingostomy. Technique of salpingectomy is again we have to lift up the distal end of the fallopian tube by holding with a forceps and move it away from the ovary, so that whenever we are with a bipolar pottery, suppose we are detaching the tube, it should be, the incision should be as near the fallopian tube as possible, and care should be taken that there should not be disturbance to the ovarian blood supply. That's why we have to lift the tube up, and then we have to give incision as close to the fallopian tube as possible. Then we can apply to this pre-tied endoscopy sutures can also be inserted. This can be, this distal end of the fallopian tube can be slipped in this suture, and the suture will be at the corner. And one more suture can also be tied distal to the first one. So two sutures are there, and then we cut the tube at the corner. This is technique of salpingectomy. So choice of surgery, it depends on, first thing is whether patient wants pregnancy in future or not. If she doesn't want, then the choice is very easy. We go ahead with a salpingectomy plus tubal sterilization of contralateral tube. Patient is desirous for further pregnancy, then what we look at is how the contralateral tube is. If it is normal looking, again salpingectomy is preferred. If it is abnormal looking, or there are high risk factors for repeat for the ectopic pregnancy, such as previous ectopic pregnancy, pelvic inflammatory disease, previous abdominal surgery, then only we go ahead with salpingostomy. Why it is preferred salpingectomy over salpingostomy? Risk of persistent trophoblast is more with salpingostomy, which requires further surgery or medical treatment and long-term follow-up also, which is seen in a quite significant number, 5 to 15%. Repeat ectopic can occur in the consort tube in around 10 to 15% of the cases. The rate of future intrauterine pregnancy is same with both the procedures. That means with the salpingectomy as well as salpingostomy, provided contralateral tube is normal looking. If there is an ectopic in previous tubal sterilization, bilateral total salpingectomy to be done to avoid repeat ectopic. Now, there is one terminology which you might come across in some of the textbooks as salpingotomy. So what is salpingostomy and what is salpingotomy? Salpingotomy is an old terminology. It is same as salpingostomy, except incision was closed with the sutures. That was a difference. Salpingostomy, you keep the incision open. Salpingotomy, you remove products of conception and then close the incision by interrupted sutures. Now, in latest editions, this salpingotomy is no more being used or mentioned, where you give incision and then you close the incision, because tubal healing is better if it is not sutured. RCOG guideline 2016 uses terminology as salpingotomy and not salpingostomy, but it is clear that here the meaning of salpingotomy is same. It is synonymous to salpingostomy, where incision is given and it is not sutured. Salpingostomy is also known as linear salpingostomy. Now, this salpingostomy terminology by some textbooks is also used for fimbrioplasty, where there are femoral adhesions, and as a fertility enhancing surgery, fimbrioplasty is done in patients of infertility. There, salpingostomy is used as a name of the procedure, and I think that might be the reason why RCOG is using salpingotomy and not salpingostomy. But the rest of the textbook, if you see Williams, if you see Teeland or Novak, everywhere the terminology which is used is salpingostomy, and I think we should keep on using this salpingostomy over salpingotomy. Now, comparing medical and surgical treatment with each other, salpingectomy least risk of persistent trophoblast. Prognosis for future pregnancy is same with both medical or surgical. Persistent trophoblast risk is same with salpingostomy and medical treatment. Now we come to the last modality of treatment with unruptured tubal ectopic pregnancy. We have seen medical management and surgical management, and the last is third is expectant management, where neither methotrexate is given nor surgical intervention is done. What is required is there has to be a USG diagnosis of ectopic. Confirmation has to be there. Patient should be clinically stable, and beta HCG level, initial beta HCG level should be low, less than 1500 milli international units per ml, and if it is less than 1000, it is better. And it should show a downward trend. There are subsequent beta HCG checkups should show fall in beta HCG, which should be satisfactory, where the fall is greater than 15%. Patient should be compliant. We need to weigh the risk of a rupture against this expectant treatment, which needs to be explained to the patient, and consent has to be taken. So that is the reason it is suitable for selected few cases. Success is seen to be more interestingly when ultrasonography shows heterotopic adnexal mass. Where the success of expectant management is greater in these cases as compared to those where ultrasonography shows empty sac or shows sac. Thank you so much for postgraduate students. I wish you happy learning. And now I have seen Williams' textbook of obstetrics, latest edition, Teeland, Novak, as well as I have gone through the RCOG guideline, and I have compiled this to prepare this topic. So, but my request to all of you is these videos cannot replace your own reading of the textbook. So my request is you use this to get the idea or to clear certain concepts. But then you shift to textbook reading is the main request I want to make to all the postgraduates. You can use these videos for the revision. That is okay. But you need to read the topic from textbooks in detail. Thank you once again.